I'm going to sit down and admit, for a year in Washington, D.C., the only practicing physician at that time who held that position. You need to know those things to understand he's qualified to talk to us.
Right.
Thank you.
Good evening. Okay, show of hands. How many people were in those two classes I taught today? Yeah, so y'all had, wait a minute, Harlan, look, make sure they all came so they can get a good grade. And how many of y'all have had some coursework, a course or more with, hey, hi, Stephen. Nice to see you. With the Shepherd program? You know, you ought to let Tom Shepherd see, you know, these guys sometime in mass. I'm not sure he's ever seen all the students that have participated.
On occasion,
Yeah, great. All right, and how many of y'all have some kind of career plans that entail medicine? Doctor, lawyer, not lawyer, but medical school, public policy, and healthcare, anything? Okay. Well, and how many of y'all plan on living in the United States for the next 20 years? You're the ones who better pay attention, because this problem we have is extraordinarily important. We're going to start out playing a little game. Let's pretend for a moment that you're walking down the street and you're with a health policy expert from France, from Germany, from Canada, and from the United States. And you get to a bar and you have a beer, and you look around the table and you say, tell me, how do you pay for health care in your country? And everybody kind of looks at each other, and the guy from Canada says, well, that's easy. We have a national health care system that's paid for with tax dollars, and we have universal care. And the guy from France says, well, we're kind of the same way, but we actually require people to pay a little money when they go see the doctor, but we have a tax-based system for universal health care. And the guy from Germany says, well, we have a little different system. We have private insurance companies. We have universal health care, private insurance companies that are heavily regulated by the government, but everybody gets their insurance through a competitive system through a private insurance, but we have universal care, and it's paid for by tax dollars. And then everybody looks over at the health care policy person from the United States and says, how do you pay for health care? And that person takes a great big sigh and says, well, okay, to follow this. If you're from 0 to 18, you're covered on your parents' policy if they have insurance. But if you're poor, you're on Medicaid. But if you're kind of poor but not as poor, you're on a policy called the SHIP policy, the State Health Insurance Program for Children. But that doesn't count the over 1 million kids in this country that have no insurance. Now that's 0 to 18. But then if you're 18 to 64, then it comes easy, because then you have insurance based on your employment. But that may not happen because more than half of the small businesses in the United States, especially in my state of Arkansas, you work, but they no longer offer insurance. So you work and you don't have insurance. But then again, you may work for a company that has insurance, but now you're a contract worker instead of a real employee, so you don't have insurance. So most of the 50 million people in this country that have no insurance are in that category. But then if you're more than 65, that becomes easy. You're on Medicare. But that's not so easy either, because you may be poor and never worked in your life, and then you're on Medicaid. But then you're on Medicare because you worked all your life and you've been paying into the Medicare system. But Medicare is divided into two programs, Part A and Part B. And you get Part A because you worked all your life, but Part B you have to pay for. And if you're poor, you can't pay for Part B. And Part B covers doctors, and it covers some drugs like chemotherapy. So if you're over 65 and you're poor, you may have hospitalization insurance, but you can't pay for the doctor and you can't pay for the drugs. But then if you're in the military, we cover you forever if you're in the military. And by this time, everybody's on their 10th beer, just rolling their eyes back. But you're in the military, and we cover them, but we only cover you in the VA hospital system. But then it gets really interested. If you're poor and you have kidney failure, you have insurance. Now, if you have heart failure, you don't have insurance. If you have liver failure, you don't have insurance. You have a stroke, you don't have insurance. But we've decided in the United States that if you have kidney failure, we'll cover you. And by that time, the other experts are going, oh my God, you got to be kidding me. And that's our system. Everything that I just described has its own administrative staff, own administrative processes. Under every effort to reform the healthcare system, people laughed and made jokes of the fact that under the Clinton plan, for example, there was 2,000 pages worth of regs and regulations. If you stacked up all the regs and regulations of the programs that I just said, it would go to the ceiling. It would be far more than 2,000 pages. So we have in this country an entrepreneurial healthcare system. We have an expensive healthcare system. We have a litigious healthcare system. We have one that has easy access and very difficult access, but we have a very expensive one. There's two problems I want to talk with you tonight about. The first one is very fundamental. Actually, both of them are very fundamental. The first one is, how much do we pay, and what do we get for what we pay in healthcare in this country? The second is a little bit more touchy-feely question, but it is equally important. And that is the question of how we cover and how we address the problem of uninsured in this country will very much determine how our society tends to evolve. So let's take the first one first. We all know, and the folks who are rising up in the Tea Party movements around the country have illustrated this very dramatically, that we're very concerned about the debt and deficit in this country, and we ought to be. But I would maintain that the problems we have with our debt and deficit have been misdiagnosed and misrepresented and not appreciated by the majority of Americans. Despite all the attention paid to the bailout, to the demographics of aging America, to fighting two wars, to the national debt, financial bailout that we have, all of these things considered, there is no way that our country will see its way out of its debt and deficit unless we alter the per capita health care cost of every citizen in the United States. The average amount of money it takes to cover your health care and mine and every citizen is what is breaking our bank. Now, it would be very realistic for you to think, why should I listen to a cardiologist from Little Rock, Arkansas tell me that? I mean, what does he know? Well, I know what I read. And so if you don't believe that statement, all you have to do is go to the Congressional Budget Office website from 2007, 2008, and 2009 and read it. It's very clear. If that doesn't satisfy you, go to the Office of Management and Budget that works for the President. Same thing. If that doesn't please you or you don't believe that, go to the General Accounting Office. Same thing. And if that doesn't satisfy you, go to the actuarial projections for CMS, which runs Medicare and Medicaid, and it says the exact same thing. Over the last 40 years, the average per capita healthcare costs have been on average 2.5% higher than our gross domestic product. Now, simply stated, that means if you put your money in the bank and had compounded interest, that it's growing 2.5% faster than what the interest normally would have been. It doubles and doubles and doubles and doubles. And that is where the essence of our problem lies. These costs come from our federal budget, not from the trust fund for Medicare. We are spending, by last projection, 17% of our GDP on health care. It's on its way to being 20%. We spent 1% in 1966, which is the year after Medicare was formed. If you look at the statistics, we spend 8 times more on health care than we do on education, 12 times more on food and aid to the poor, 30 times more on law enforcement, 78 times more on land management and conservation, 87 times more than we spend on our water supply, and 830 times more than we spend on energy conservation. Now, you don't need to remember the numbers, just remember the trend. And remember that as healthcare grows, the rest of these programs get crowded out. So we're spending a lot, but what do we get? Well, we're spending 17% of our GDP. The next closest country, developed economy, spends 8%. So we're twice as high as the next most developed country. For that, you would think that we would have the best healthcare, population healthcare in the United States. We do have fine hospitals, but if you look at population-based data, we're not number one. We're not number two. We're not number three. We're not even in the top 10. You can get a t-shirt that says, congratulations, you're 37th. We stack up between Slovenia and Costa Rica. Now, it is true that Slovenia and Costa Rica probably should beat us in soccer, but not in healthcare. So, what is the impact on this? Well, for small businesses, it is driving small businesses out of business. And more small businesses are dropping health care in order to for their employees in order to stay in business. The premiums are growing faster than their ability to keep up. For large industries, you saw, if you were watching and paying attention, with all the throes that General Motors went through and Ford, the benefit structure for their employees is what was sinking their ship. Our large companies and businesses become less competitive in the world market because of the rising cost of health care that we have to spend. On Medicaid, which is how we take care of our handicapped and our impoverished population, it is putting 25 states in deficit spending because it's a combined program with federal and state dollars. 25 states are in deficit and the rest of them are not far behind. Now, they're not going to be in deficit because they can't spend deficit, but it means they have to cut back on other programs. In Medicare, what's going to happen to Medicare? It's not sustainable. There are over $1 trillion of unfunded mandates that are going to occur in the Medicare program over the next generation. So if the United States is to achieve any kind of financial stability, we have to address the per capita health care cost. But there's a paradox there. And the paradox is that the widespread support for cost reduction and for appreciation for this is really not felt. The burden of health care is not felt by the people that it's mostly impacting, and that's in middle-class America. The full weight of it is going to be approaching $17,000 per family per year, and that's because of premium cost, out-of-pocket costs, lost wages because of what their company would have paid them. They're now having to pay in premiums and their Medicare costs. And what is projected is that the standard of living, and you're already starting to see this, is going to start to fall a bit. And this will then spread into higher income brackets, and so it is eroding the very basic economy of the working family in America. These problems have been going on for years, and they show every, if you look at the graphs, they show every trend that they will accelerate between now and 2014. Now, the second problem I want to discuss, or just mention, or make mention, is how society will change. And this gets to the class that Professor Beckley asked me to participate in today. It is a very fundamental question that health care is a cornerstone of how Americans view one another. Lynn Nichols, who actually went to college in Arkansas and is the head of a healthcare think tank in Washington, recently wrote a paper, and in it he asked a very important question, and that is healthcare financing, the way we pay for healthcare, a moral question? Do we want a society where where everybody has access to healthcare, and if we want that, how much are we willing to spend? How much pain are we willing to endure to have that? The fundamental truth about healthcare in every country, according to Uwe Reinhardt, who's a healthcare economist at Princeton, is that the way that you fund healthcare is a reflection of your moral character for the nation. So the fact that we have 50 million people without access to healthcare and the lack of health insurance is a mortality predictor. People without health care insurance die. They die for every disease state that you want to list. Their rate of dying is greater than an insured population. President Obama made this a moral issue when during his campaign and when he was elected, he asked a simple question, and that is, do we want 50 million people without health insurance, and do we want 700,000 bankruptcies that occur in small businesses in the United States because there's no health insurance? So there's three questions of social justice that deserve to be asked. Is health care and related issues of special moral importance to the United States? Are health care inequalities unjust? And if so, who decides what's unjust? And what is the fair allocation of resources that we have for health care? To address these questions, I'm going to do something that I do for a class that I teach in Arkansas. But for those of y'all that when I tell you this, you might roll your eyes and think, oh, God, here we go. But it's interesting to go back and look at a political philosopher from a long time ago who looked at our democracy and made observations of our democracy. He asked the question, why does an American democracy work? And what does it take to sustain that democracy? And the person I'm referring to is a gentleman named Alexis de Tocqueville, who wrote a book called Democracy in America in the 1830s. And it is a classic book because he doesn't provide answers, but he asks kind of eternal questions that we should continue to ask ourselves about a democracy. Those questions involve what procedures, what laws, and what social philosophies need to be in place to perpetuate a democracy like our own. De Tocqueville felt that there was really three reasons that the American democracy survived and will continue to survive. The first one was that he saw our heterogeneous origins as a plus, that we learn to tolerate, we learn tolerance from one another. The second was our Constitution, which basically is just a social contract. Our Constitution is a contract between the citizens of this country and our government. But the third thing that he talked about, and very, very important, what he referred to as habits of the heart. Now, these are the mores, these are our cultural traditions. These are the respect, the ethics, the morality that we have for our fellow citizens. They are our American creed. This is the stuff that when you're in the 6th grade, you stand up and say, I pledge allegiance, liberty and justice for all. Or we hold these truths to be self-evident. These are sacred words. They are ingrained in our population and in our kids and in ourselves, that this is what we are as Americans. It is what holds us together. De Tocqueville felt that if we lose our habits of our heart, we lose our creed, that it will undercut our democracy. In talking about this, he talks about equality of condition. Now, equality of condition in de Tocqueville's writings are kind of hard to understand, but really if you distill it down to what he's talking about equality of opportunity. He's talking about how people view their opportunities within our society. And he felt it was more important than our liberty and more important than our freedom. That equality of condition is what bound our heterogeneous population, our black, white, brown, and yellow, our Jewish, Christian, Muslim population, north, south, east, west, rural, urban, male, female population is what binds us together. It is the American dream of upward mobility. My wife and I like to go to movies. Have any of y'all ever seen Charlie Wilson's War? Y'all remember that? Anybody? Well, very quickly, for those of you who did not, Charlie Wilson was a Texas congressman who was a sort of a bigger-than-life kind of character who single-handedly convinced the United States government to fund Stinger missiles to the Afghan rebels the Mujahideen, who were fighting the Soviets, and drove the Soviets out of Afghanistan and led ultimately to the rise of the Taliban. True story. Charlie Wilson is played by Tom Hanks in the movie, but was noted in the movie and in real life. He drank too much, and he surrounded himself with very attractive young women who were his aides in his office. And there was one scene in the movie that was absolutely, in a heartbeat, it captured what I'm talking about. And that was Representative Wilson, Charlie Wilson, was in Pakistan in an Afghan tent city of refugees, people who had been driven out of Afghanistan. And one of his attractive young staff workers was talking to a little Afghan girl sitting on her mother's lap. This little girl and mother had been displaced. And she was the young staff worker was a very attractive young lady and very cheery, and she was trying to think of something to say to this young child. And she looked at her with this bright kind of cheerleader kind of face and said, "Well, what do you want to be when you grow up?" And at that moment, the camera backed away and you saw this little girl, and both of her arms had been blown off in some kind of an explosion. And the whole idea that you would ask an Afghan child in Pakistan with no arms, what do you want to be when you grow up, is a very American question, because we think that you can be anything you want when you grow up. It is part of our dream. It is part of our equality of opportunity. That is part of the nature that we have about the way we view one another. It is not exportable. It's a very unique American feeling about how we feel towards ourselves, our children, and our fellow citizens. So de Tocqueville thought that this heterogeneous population of ours, and it has never been more heterogeneous, was held together by habits of the heart and by this preservation of our equality of opportunity. And he saw things like education, transportation, access to capital, and perhaps health care as being the pillars of this process. So we have now been hit over the head again about a health care to pay. Most of you in this room probably aren't old enough to remember when we did this in 1992, 3, and 4. And then in my lifetime, we did it under President Nixon. And the history of it goes on and on and on and on. You've heard about the debate about should there be a public program or private program, and who should pay for it, and mandates for this, and employee mandate and individual mandate. But there are some questions that we didn't ask that should have been asked, and we ought to ask about our health care. For example, how long do we want to work? Because how long you work and how long you stay in the workforce determines about how you pay for your health care. How productive do we want to be? How does productivity tie into health care? Do we want to allow more folks to immigrate to this country? And how do we pay for them? At what age do you get government benefits? How much do we pay for those benefits? Should we vary the amount we pay by our ability to pay? How do we improve on the current government system and make it more efficient? Who are the programs for? Are government programs for the people we're paying for, or are those programs designed to pay for medical school education, which is what they do? Many of you going to medical school, your education is being supported by Medicare funds. If Medicare funds get cut, the ability for your medical schools to take care of you, it will not be the same. Or for pharmaceutical companies or device companies or durable medical good companies. Who are these programs for? How should we apply advanced technology? Who should get it? Which one works best? Who says how it works best? We never ask the question, does anybody care if I'm healthy? Or should I care if you're healthy? And what should I do to preserve that? We never ask the question of what is my responsibility to pay? Pay for mine or pay for yours? We never ask the question, what is an individual's responsibility to take care of themselves? And if they don't, should there be a penalty? We ask the question, should we look at what to do at the end of life? And that it was a PR debacle about what happened when that question was asked. We never asked the question, how much as a nation should we pay for health care? And when is enough enough? And what are the consequences of having no insurance, which is well documented, but was never really widely talked about. And then there's the political questions. I mean, the political questions of what's going on in Washington have been phenomenal. Are our political institutions so paralyzed right now that they cannot produce a document and address a problem that's going to eat our lunch in the next few years? We didn't ask the question of, is health care reform and deficit reduction the same thing? And if they're, which one should come first? Should we expand health care, or should we try to address cost containment? We didn't ask a very real question, is politically, can you have altruism and collective self-interest in the same kind of approach? I mean, I want to do what's right for you, but I want to do what's right for my family also. We never asked the question that if we have a reduction in health care spending, is that really a form of rationing? And if it's not a form of rationing, why is it not? And we never asked the question, which is very important, is health care reform really a policy problem with political elements, or is it a political element with policy problems? And namely, can we have a health care debate without it digressing into a ideological debate? This nation has to solve this problem. And I'm going to give you a couple of examples what happens when you solve things and also when you don't solve things. You know, a lot of times an event will set our nation on a trajectory that we really didn't think we were going on and produce consequences. But sometimes legislation will do the same thing. Let me give you 4 examples of unintended and unpredicted consequences of major legislation, and they all occurred between 1964 and 1966. The first was immigration laws. You all don't remember, you're too young, but our immigration laws used to have a quota system, and we changed that in the spirit of fairness in the mid-1960s, which was probably the right thing, which was the right thing to do. But the result was that nobody predicted that in 2010 the Hispanic population in the United States would exceed the black population. And the result of that has had major consequences on the demographics, on the political climate in many states in the United States, and will continue to do some. But it has greatly changed the political landscape that we have in this country. The second, and actually the second and the third, is the voter right legislation and the civil rights bills that were passed in 65 and 66. They did away correctly with the horrible Jim Crow laws. They assured the African American population their voter rights. But what it did was, that people didn't predict, was that the South, which had been solidly Republican from Lincoln to Roosevelt, and then solidly Democratic from Roosevelt to the passage of this legislation, then shifted back to the Republican category and has remained there. And it changed the political structure in this country. The last piece of legislation is in 65, Medicare and Medicaid. And Medicare and Medicaid, coupled with Social Security, it lifted more people out of poverty than any piece of legislation ever has. Millions of Americans, elderly, were no longer impoverished thanks to these legislations. But it also passed a entitlement program that, frankly, we cannot afford to go forward in its current form at the present time. So we are burdened now with a entitlement program which is morally the right thing to do, is ingrained in our culture, but we cannot afford in its current structure. The Commonwealth Fund, not long ago, and the Commonwealth Fund is a wonderful think tank in New York, did a study looking at not just consequences, but the lack of consequences, or the what happens because you didn't do something. Not because you did something, but because you didn't do something. And it looked at the health care policy proposals of Nixon, of Carter, and of Clinton. And it projected what would have happened if these proposals had passed. As you recall, I said that we are spending 2.5% more per person per year than GDP. If you had lowered that to just 1% greater or 1.5% greater, Nixon and Carter would be saving this country $1 trillion per year. Now, the Commonwealth Fund didn't say their policies were right or wrong. They were simply saying, had we done this, this is what we would be doing. We would be saving $1 trillion per year, which is more than the stimulus package that was passed in the first year of the Obama administration. The Clinton plan would have saved about $700 billion per year, recurring cost. Most of these monies would have accrued to the federal government. So we're at this crossroad. We are at a position where if we do something, it is going to have consequences, and if we do not do something, it is going to have consequences. Mr. Clinton, when he did his, tried to secure universal health care, regulate private markets, enforce an employer mandate. He tried to control costs and transform a delivery system. He tried to do all that at once. President Obama is trying to do the same thing. But what Clinton learned was, and perhaps Obama has not learned, is that each of these goals has its own constituency that comes out against it, its own opposition. The thing that we learned from President Clinton's efforts were that no matter how much people say they want to have change, it's never inevitable. That the status quo becomes deeply entrenched and people are very difficult to make people change. Most importantly, that when we talk about cost savings, when you save money, somebody else has another word for that cost savings, and it's called, that's their profit. And they will fight very hard to maintain their margins within this marketplace. We forget sometimes that there are many people that are pretty happy with their health care, even though it costs a lot. We forget sometimes that expanding governmental control in a country that's pretty ambivalent about government is a hard thing to do, and that paying for health care is formidable even in the best of economic times. We also are learning firsthand that our political institutions are designed to prevent things like this from happening. And I'm afraid we may learn that the window of opportunity to do something is going to close rather rapidly. And we may be, just like we were in '94, that we just leave this for another 10 years, another generation. But to go back again to the cost curves from the Office of Management Budget, the General Accounting Office, CMS, we don't have 10 years to solve this problem. So we're at a cultural crossroads and a physical crossroads. If we don't take care of this problem in the very near future, there's going to be consequences, no matter what we do, if we do something or if we don't do something. And it may, as I told one of Harlan, Professor Beckley's classes today, it may well be that bright young folks like yourselves, this falls in your lap to solve, because it's going to have to be solved one of these days. I wish I had a more optimistic, uplifting message for you, but I mean, folks, that's the way it is. And I think we have time for questions and things, right? Okay. Yeah, sure. Or comments, you know. Thank you.